Well, thank you for that lovely welcome, and it is truly an honour to be here as you celebrate the RAIN study, which is an amazing example, as we've heard a little already, and we'll hear some more about how fantastic RAIN is in terms of its capacity for impact or influence. And I'm really pleased to be here. I acknowledge the traditional owners of this land, as well as the Gadigal people of the Eora Nation from the Sydney area that I come from. And I also want to say kia ora tātou to all the colleagues that might be associated with Aotearoa, New Zealand, since that's where I'm from. And I also acknowledge our Māori and Pacific people who, without them, I wouldn't have anything to say to you today. So I hope that what I have to say is useful. This is kind of what I hope to get through in about 25 minutes or so, not keeping you too long from your morning tea, and also not keeping you too long from hearing about some more wonderful things that RAIN has done and RAIN is doing. But I did just want to talk to you a little bit about the value of cohort studies a little more than you've heard already. It is really the case that when we set out to design an explicitly longitudinal study that captures a particular population of interest and tries to understand why we see the outcomes that we see for that population, and we follow them up over time and collate that information and turn it into stories, we have a tremendous power to make change, not only in health, actually, but outside of health as well, because so much of what happens in health is not just influenced, of course, by biology or by health, but what is going on in the wider social environment. So I really hope that I can convince you, using examples from the one that I'm most familiar with, growing up in New Zealand today, how impactful these studies can actually be, and I'm sure you'll hear more of that as the day goes on. I do want to talk to you about some specific examples of how we have translated evidence from growing up in New Zealand, evidence that will be similar to that collected in the RAIN study. And then I do want to talk a little about the future of where we're going with cohort studies, which you've heard a little from Beck and others about this morning already. This is an amazing book if you haven't read it already. Helen Pearson has written a book called The Life Project. It talks about the 70,000 families and children who've been involved in the UK longitudinal studies since 1946. And it talks about the tremendous value that they have brought to health policy and policies outside of health. And if you haven't read it, then I suggest you do. It's a really easy read. I think I read it in about 45 minutes. It was so compelling. Perhaps one of the things that's most disturbing about it is it talks about how mad and strange the people who lead these studies are, which is a shame. But I do think you have to actually be quite passionate, resilient, as we heard earlier, and put up with quite a lot of change and uncertainty when you're running these studies. And it is true, we stand up and present the results. We always value the participation of our cohort members, because without them there is nothing to present. But actually behind the scenes, it's a bit like seeing your head above water, but the paddling frantically with underneath to keep things going. So we are a little mad, aren't we, Romola and Beck and others who may appreciate that comment. But I think the things that set us apart with cohorts is we can do so many things that other studies can't, that other data sets can't, particularly over the last couple of decades where we've had the rise of administrative data. If we think about the New Zealand example in particular, the great praise that's been heaped on the integrated data infrastructure that we've had for the last decade in New Zealand, where people have said, this is all we need. We just need to be able to link administrative data together and we will know everything about all of our population. Well, I hope to convince you that that's not actually the truth. And really, when we add in cohort studies and the things that they can tell us about ordinary lives, we can get some extraordinary stories and some extraordinary information that can really create change that other data sets really can't. And part of that is because we get to hear the voices of the people who are living those everyday lives. Those are so critically important to help us understand the patterns that we see in some of our administrative data and our health statistics and our education statistics, because they are very bland on their own. The deep dive that we can do into people's lives in cohort studies helps us to understand why we see what we're seeing, what the inhibitors and enablers are of people engaging with some of those administrative data sets. So it's actually that sort of value that I think is really special about cohort studies. So let me just divert a little to growing up in New Zealand to give you a couple of examples of what I'm talking about. So growing up in New Zealand did start unbelievably about 20 years ago after I returned from the UK. And Beck is right, I did do my PhD on an intergenerational study, actually the Aberdeen Cohort of the 1950s, where we revitalised a study that started in the 1950s and linked all of those women, 5,000 of them, to every reproductive outcome they had between 12 and 50. So we were doing big data linkage back at the end of the 1990s, well before it was thought of as something that is so brilliant today. But anyway, that was an exciting study and it gave me my passion for longitudinal studies, actually. So coming back from the UK, I was lucky enough, I guess, to be in a position where I had a little bit of time on my hand. We heard how important time is and how we use our time is important. And I was quite junior at the time. I was a clinician, a paediatrician, studying to do my advanced training in paediatrics, but I got sucked into public health medicine instead. And for my sins, I got to set up and lead the Growing Up in New Zealand study from its inception in 2004-05. And so I'm going to tell you a little about that today. The reason that study started, and I hope some of the things that we've been able to do since it started, is because even though we think New Zealand is a wonderful place to raise children, I'm sure people in Western Australia think that Perth and other places here are great places for children and families too, we know that when we look at our statistics, that actually there are children who are falling behind and families who are falling behind. And despite the best efforts of many to actually improve outcomes for some of our population, we are still seeing vast inequities. And that was the case in New Zealand, certainly for our Māori and Pacific children, but also for those who are experiencing poverty and cumulative exposure to disadvantage. And I'm going to talk to you a little bit about those things today. So we recruited nearly 7,000 children. That was about 10 times larger than the other studies in New Zealand that everybody seems to know about, the Dunedin study and the Christchurch study. They have around 700 left in them today, but they have been going for nearly 50 years, which is pretty amazing. But we had nearly 7,000. We also were a bit like RAIN in that we started in pregnancy. We really wanted to understand the influence across generations. We wanted to understand the influence of the first 1,000 days, that perinatal period, for that period's influence on what happened to children as they grow up postnatally. So that was a little bit different than some of the other growing up studies that were happening around the world, including Growing Up in Australia, or LSAC as it's called, Growing Up in Ireland, Growing Up in Scotland, and Millennium Cohort Study, all of whom we have collaborated with for the last couple of decades. They all started when the children were born already. We started in pregnancy. Perhaps most importantly for a cohort study, and we've heard a bit about this in terms of retention, is that the population we recruited was generalisable to the population of births in New Zealand now, today, the 21st century. So 1 in 4 children were anticipated to be Māori, 1 in 5 Pacific, 1 in 6 Asian, and over half to be New Zealand European. And even if you didn't do a maths degree like I did before I went to med school, you know that adds up to more than 100. And that's because most of our children actually represent themselves with multiple ethnic identities, and those ethnic identities change over time. Now that's the case in New Zealand. I'm not saying that's necessarily how it is here, but it would be interesting to compare. So really importantly, that cohort could tell us about this generation of children. And we worked with 16 government agencies from the beginning. So not just health, not just social services, not just education, but 16 of them. And we worked with them to try and understand not just what was going wrong, but actually what works. What works to support children and families. So not just about shaming and blaming, but actually what can we do about these things. And it's actually quite difficult to collect evidence about what works because normally we focus on risk factors. We know what's going wrong. All our admin data helps us understand those risk factors really well. But actually when we want to understand what's going well for our families, what is creating resilience in the face of disadvantage, that requires a different approach. And again, that's where cohort studies have a unique advantage over some of the admin data because we can actually go out and ask our families what is happening in their lives? What are the things that are working? What are the resilience factors? We can use the data to shape different outcomes, to tell us what we might do to support well-being, not just to keep understanding what is creating what is going wrong for some of our population. So that's what we set out to do from the beginning. And this is the way we conceptualised it. This is our double puddle model. I hope you heard that correctly with my New Zealand vowels. It's not so good to say in the UK. But actually, it is a double puddle model because what we do is we see our 7,000 children at the centre of those puddles. Their health and well-being, their biology, that is at the heart of everything that we're doing, and we're following those 7,000 children as they age over time. But of course, children don't grow up in a vacuum. They grow up in dynamic interaction with all of the environments around them, like those onion rings around that child. So that's their immediate family, which is critically important in the first 2,000 days, of course, continues to be important, but perhaps as they get older, they're engaging more with informal and formal society, and the outside ring is all the way out to the policy environment. In New Zealand, that's the national policy. Here it might be state or federal, but it's nevertheless this rings, concentric rings of dynamic interaction, not just a one-way interaction. So every time we went to see our 7,000 children and families, initially just their parents were speaking to us, we wanted to collect information, not just about the child, but about each of these environments that were surrounding them. It's a double puddle because we're collecting that over time. So we're interested in the child's development, but we're also interested in how the environments around them are evolving and changing. And we want to look at the trajectories of the children's development, but also the trajectories of what's happening in the environment around them. And that's a slightly different way to looking at things that we might usually look at if we're thinking about risk factors and working out what is going on for different groups. You can see down there a figure, or I hope you can, that represents the work of the Harvard Centre on the Developing Child. That's been a centre that's probably guided most of our work in the cohort space. It's very interested in resilience and resilience factors. And so we have been very interested too to understand what shapes resilience in our New Zealand context for our children and our families, so that we can convert that into strategies that might actually enable more children to experience support and to have better well-being as they move through their lives. Now, resilience is an unusual thing in that it's not fixed, it's not innate, no matter what people think. There might be some factors that are innate, but mostly it is context dependent. So the context really matters. And so each time we ask what is creating resilience, the other important part of that question is what is the context we're interested in? Who are we talking about? Okay, so let's talk about a few results now that I hope will demonstrate what we've set up really over the last 2 decades has helped us to have some influence, to have some impact on what we know about our children and what we can do differently in order to improve their well-being. I'm going to start by focusing on the things that we usually focus on, which is the mad, the sad, and the bad. And we do. We tend to focus on those things, and we will focus on those things because we want to make them better. But actually, this is just the beginning of exploring the cohort. We can describe things in our cohort the same way that we can in admin data. So for example, here are our 4.5-year-olds. This is at the end of their first 2,000 days. They're ready to start school, and 98% of them were in early childhood education. That aligned with what the Ministry of Education was expecting. Of course, their early childhood education was quite diverse, and the quality differed quite substantially, and we have a lot of information on that. They're also quite happy. It's quite important. 80% of their parents reported them as being happy and healthy at 4.5. Right? They didn't necessarily always tick all the boxes if you did a health check, but 4 out of 5, their parents thought they were doing well. The sad thing about that is that 1 in 5 didn't, so that's not so good either, 20% falling behind. These are children in the cohort, a bit like your cohort study. We have a permission from 50 families to use their photographs, but not their names. So these are children who actually sit in the Growing Up in New Zealand study, so I just want to acknowledge them at this stage. We can also look at change over time, and we looked at mental health. We've heard how important that is. It is an important feature, of course, in the perinatal period as well. So we were able to look at mums' depression scores, depression factors in pregnancy, and then postnatally. And we found, to our dismay, actually, that 1 in 8 of our mums were experiencing depressive symptoms during pregnancy in their last trimester, their 3rd trimester. That is huge. Only 50% of those women were receiving any care, so not just medication, but any particular behavioural or other interaction. The others were unrecognised, and that's really unfortunate, because that puts them in a poorer position to look after their babies once they're born. But then cohort studies can follow up what happens afterwards as well. So 1 in 12 mums had symptoms of postnatal depression by the time their babies were 9 months of age, or in that first 9 months of their babies' lives. 50% of those were the same mums who had problems in pregnancy, 50% were new. So it changes. This flux, this change of who's moving in and out gives us really important information to say what helps us with that change, what creates the change for those mums. The dads got the blues too, but only 5% of them. And actually, if mum had the blues, dads weren't so worried. If dads had the blues, mums were particularly worried. You work that out. We could ask about the children as well. At 4.5, the parents were telling us about their children. I'm going to tell you slightly later on that at 8, the children were talking for themselves, and that's really exciting. But at 4.5, 1 in 3 of the families were telling us their child was being regularly bullied by their peers. We were horrified by that statistic. New Zealand has a horrific rate of bullying of adolescents. We know that from OECD studies. We did not expect 1 in 3 of our children to be bullied in their preschool years. The shame of it is that when we ask the children themselves at 8, and of course you don't ask about bullying, you're very clever about the way you ask these questions, and you ask multiple other ways of finding out about bullying without using that word. That's one of the things that longitudinal studies are quite good at. But they actually told us that 35% of them were experiencing bullying at 8. So that's really sad too. So we have a problem in New Zealand, and we need to work out what to do about that. We can find out about who engages with routine services, what the enablers of those engagements are, what the inhibitors are, what the families really think of those services, not just the ones who actually attend the services and we get their measurements in the admin data set. We can find out about the ones that don't go as well, or the ones that go and don't follow up. So we ask those sorts of things. And actually not everybody, even if services were free, engage with those services, free health checks, free dental checks. Only around 70% of our entire cohort went through with all of those checks in the preschool period, and it was not just about cost. We can find a lot out about the families, that matters, about their homes, about their household situation, about who's moving in, who's moving out. And we can also find out about the nature of the relationships of the people who are there. So one of the things that the trust relationship builds in a longitudinal study, and that takes years to develop, is that you can ask some of these families some really sensitive pieces of information and they will share those honestly with you. And we've checked that out, we've validated that fact. So we could ask about things like family violence. And unfortunately, 4%, 1 in 25 of our children were regularly seeing their parents physically violent to each other. And that's not psychologically or emotionally violent. And of course, there were questions about that too. That's too many at 4.5. And maybe that has some connection to the bullying. So those are things that we're working out as well. But just above the description, we can do some other things. We can bust some myths with our cohort data, with the information that comes out of it. This is about immunisations. We know that in our childhood immunisations, which are so important for health and well-being, that we have some children who just never receive their immunisations or receive them very late. And we've also done some research to show that timeliness matters, because those children who receive their vaccinations late in the first couple of years of life, much more likely to be admitted to hospital with respiratory disease that would have been, we hope, avoidable or less severe had they had their immunisations on time. Now, our Māori and Pacific children are the least likely to receive their immunisations on time. The response to that and a strategy is to try and tell our Māori and Pacific families how important immunisation is, to educate them. I hate that word. Because when we asked our families what their intentions were about immunisation before their children were even born, our Māori and Pacific families had the highest intent to fully vaccinate their children on time. They knew all about how important immunisation was. They didn't need us telling them about it. They knew that. But unfortunately, the last gap that you see there, you see the pattern of intention to actual reality reversed. So life has got in the way for those families. The complex situations, the way we deliver those health services did not meet the needs of those families. They did not manage to get their children fully immunised, and they paid the price for it in terms of admissions to hospital and poorer well-being. But it was not an education problem. Similarly, we talk about obesity. 1 in 3 of adolescents or children in New Zealand is overweight or obese. By the time our children were 4.5, 14% of them were measuring as obese, because our interviewers at home were measuring BMI with lots of techniques that the ministries of health and others use as well. As well as measuring, we asked the parents what they thought about their child's weight and whether they thought there was a problem. And this is what this slide shows you. So you can see that 10% of the families, the mums and the dads, thought that their child was underweight. In fact, 0.3% of our cohort were underweight, including our Asian children. And there is a myth that our Asian children are more likely to be underweight. Not if they live in New Zealand, they're not. They are not likely to be underweight. They're also less likely to be obese, but they are unlikely to be underweight. But the problem is at the other end, the overweight end. 14% measuring overweight, but actually only 1 in 3 of those families recognising that their child has a problem that we would define clinically as being overweight or obese. Now that means that if we as clinicians or other workers try and give some advice to that family to see if they can make changes to their children's weight, which we know is very difficult, but suppose that we try, why would they take any advice if they don't think there's a problem? So that is one of the things that we can get beneath this idea that just giving advice is going to solve the problem as well. Perhaps most importantly, we can find out who's missing out on the services that we offer routinely, the universal services that we offer to all our preschoolers in the preschool period. And unfortunately, we found that 10% of our cohort who were engaged in our study, and we saw them every time we visited, were not engaging with any of the data that was being collected by the Ministry of Health. They were not on the National Immunisation Register, and they had not completed their before school check, which happens at 4.5, supposedly for all our children. That before school check that the Ministry of Health conducts then defines what services we provide for all of our children. 10% of our children from the cohort are missing out, and they are our least advantaged children. So we are perpetuating services that will not meet the needs of those who have the greatest need. And that is something that the cohort study could point out. And we could help them understand also by what the families were telling us about why they either had or had not engaged, what we might do about it. We can also look at things that are much more complicated, and I just want to finish with this example of poverty. Such a big issue, such a big problem everywhere in the world. It's equally a problem in New Zealand. And often we will measure poverty at a population level using a proxy statistic like income, or perhaps, and that can be relative income as well. We might use area level deprivation. We might use many different ways to actually understand how many families, how many people in our population are living in deprivation, in poverty. But actually, when we think about poverty, particularly for young children in their first 2,000 days of life, it is a really complicated environment to measure. And one of the things that cohort studies can help us with is we can measure a whole lot of those different components that make up an advantaged or disadvantaged environment for our children. Some of those are about things that are very close to the child, things about maternal well-being, like depression. Some of them are a little further away, like the relationships that the parents have or that the parents have with their communities. Others are more standard, like their income, whether they are seeking work and cannot find it, so they're unemployed, whether they're receiving benefits, whether they're living in state housing, those sorts of things. So there are 12 factors that we could look at across our population, and we could look at them at 3 time points: in pregnancy, at the end of the first year, and at the end of the second year, the first 1,000 days for our children. And we looked at how those added up, and we literally just added them up. How many of those did they experience? Because actually they do cluster and they do accumulate, but not in ways where you just pick 1 or 2 and you can work that out. It's kind of more about the additive bulk, if you like, the burden that we see by having these cluster and accumulate over time. This is what we saw when we looked at those 3 time periods, and we just added up the number of those 12 factors that each of the families experienced over their first 1,000 days. So a total of 36 they could have had. Thankfully, nobody quite at that level. But actually what we saw is a very different distribution for our Māori and Pacific families, which are in the dark blue and the green, than our European or Asian families. So it's not just a one-off measure. This is about clustered and accumulated disadvantage. We're seeing this greatly different exposure to cumulative disadvantage, frequency and duration of exposure to risk. So what we did is then we said, well, what does that mean for our families? What happens? So we looked at what it meant for children at the age of 4.5 at the end of their first 2,000 days now, before they started school, to have been experiencing clustered disadvantage over their first 1,000 days. And we saw these graded pictures, and we saw them for virtually any outcome that we put at the end of that. This one's about overweight and obesity. So you can see that the children at the top who've experienced the most disadvantage right throughout their first 1,000 days, much greater risk of being overweight or obese by the time they're 4.5, compared to the group at the bottom who've experienced none of those risk factors at any of that point during their first 1,000 days. And then you've got a graded impact of people who experienced some, but not always, throughout. And you see that graded effect on overweight and obesity. You can also see it on behaviour, perhaps even more markedly so on behaviour. You'd expect 10% of our children to be in the abnormal category for behaviour at 4.5. We see 44% of our most disadvantaged children. That is 10% of our cohort. It's not an insignificant number. That's 700 children in the Growing Up in New Zealand study. And it's nearly half of them who are experiencing this poorer behaviour. It's only 4% in the group that experience no disadvantage, and you see that huge gradient. We see the same gradient if we put numeracy, if we put literacy, if we put vocab in there, readiness for school, early mental health issues. Anything that we put in there, we see this graded picture. So disadvantage is having this cumulative effect early in life, and we're seeing comorbidities develop for our children, so that those who are experiencing that greatest advantage are already at significant disadvantage before they enter school. Okay, so let me pause there for a minute. We've described the risk factors, we've described the problem, but we wanted to do something different with it, because if you look at that last graphic there, while 44% of children in that highest group experienced poor outcomes, over half didn't. So what was different about the 56% of children who did not experience problems in behaviour, for example, or equally in any of the other outcomes? So we wanted to look at that, and to do that we went back and we co-designed how we would look at that with the communities who were most impacted. We went to South Auckland. South Auckland, 80% of the families live in cumulative disadvantage. 80% of them are also Māori and Pacific. It's no surprise that those things overlap, but they're not completely equivalent. So we went back to 1,252 of their children who were part of Growing Up from the beginning, and we looked at what made a difference for those children who did not appear in those poor health outcomes or poor behaviour outcomes. And we took those results also back to the community once we'd done the sophisticated analyses, or the clever analyses maybe. Sometimes we think we're clever. And we took them back to the communities and we said, this is what we think your collection of stories is telling us about what makes a difference, what protects your children. Here are the sorts of things that came out. They're really perhaps things that we could imagine anyway, but the power of the numbers, the power of those stories, that these are real people's lives, told us that this was the case. Families who had really strong identities, where their children were culturally connected to their communities, where they were connected into their communities and felt they belonged, where they had strong relationships outside of their own families as well as internally, where the relationship between the parents or the extended members of their family was strong. That was important. And they also felt that they could engage with community and their community supported them, so that sort of inward process. Those were the things that fell out of the analyses that we did. And we took that back to the communities and said, what do you want to do with this? How can we help you protect your children while we try and deal with this thing called poverty that's going to take us generations to deal with? What can we do to protect the children now? These children who are growing up today, our future adults and our future people who are going to support us in our old age, some of us getting there rapidly. So this is what we did. We went back to the communities, we went back to people who worked in those communities, and they set up something called loud libraries. So they set up processes whereby they created safe places for families to gather, to come together outside their homes, because people didn't always feel safe in their own homes. But they had a home away from home, and services could come to those families and they could support each other in those collections of families. So the libraries that used to be quiet places are now quite buzzy and loud in South Auckland. If you go there and you experience that, you might know why. We're evaluating whether that's going to make a difference to some of these children coming through, and we hope that it will, because it's based on real stories, lived realities, and actually on the context of these families and what they said would make a difference, not just what we said as academics. We also took that information and a decade of information. So we've heard about the hundreds of papers that come out of these studies, and the same is true of growing up in New Zealand. We also produced hundreds of policy relevant outputs because we worked with these 16 government agencies over the last 2 decades. And we worked in particular with Jacinda Ardern's government in the child poverty area. And then we worked with the Department of Prime Minister and Cabinet to work out how could we roll out some of the strategies that were falling out of this collection of evidence from growing up in New Zealand over the decade before. And we summarised it into an A3 sheet, believe it or not, thousands and thousands of documents and pages. But we worked with government to say, how can we actually turn this into something that works? Here's a little bit easier to see. It's a small piece that I've pulled off that larger A3 document. There are hundreds of pages that sit behind it. But we looked at the international evidence. We probably looked at what was coming out of RAIN study as much as other studies around the world. And we said, how can we turn this lived reality, this evidence that is coming from this cohort study, who represents the families growing up in New Zealand today, into strategies that we can roll out and help others. Wrap support around families. Not just blame them or not just label them, but actually what can we do? And that's what this set of outcomes does. I don't expect you can read that, but we tried to put some tangible things that we could do in the perinatal period, in the immediate postnatal, and the early childhood period. And it crossed over not just health, but other sectors as well, education and other sectors acting in that space. So that's what came out of that decade of work. 1 page. Oh, well, never mind. As I said earlier, and I won't go into this because I'm nearly out of time and I want to give others a chance to talk about their wonderful work as well. I think one of the things that's critically important while I've focused here on the first 2,000 days, which we know are critical for setting trajectories, it's also really exciting when the cohort members start talking for themselves. And at 8, we actually had a separate questionnaire that was just for the children to answer. They also became our own little scientists. They measured the temperatures in their homes and their schools to find out that New Zealand homes are indeed cold, and their bedrooms are some of the coldest places to be in some of those poorly insulated homes, which also helps us explain why we see such high rates of respiratory illness, rheumatic fever, things that we shouldn't see in a first world country. So that was exciting. We also fed into the New Zealand government's wellbeing strategy, which of course across Australia there's a lot of work going into at the moment, but most of the things in that strategy are what works. What are the things that families need? We don't get those from things that are administrative. We get them by asking families, and that's what we can contribute in this space. There are also some opportunities that come along when you're running a cohort study, some of them pretty unwelcome, to be fair, and COVID-19 was one of those. The great thing, I guess, about having an existing cohort study when something like this comes along, despite how terrible it is that we understand the health and well-being of the cohort before that global hit, before there was this inconvenience that stopped our lives and stopped us travelling and stopped everybody doing all sorts of things. So we could run a particular survey quite easily because we already had connections to 6,500 families still at that point and find out what COVID-19 lockdowns were doing to those children in terms of their mental health, in terms of their well-being, in terms of their connections to school and to family and to other sectors. So I won't go into that, but you can go onto the website and see all of the results that came from that. And now at the 12 year, which only happened last year, we've been able to follow up and see whether some of those children have continued to have some of the stress and anxiety that was starting to be demonstrated in that COVID survey, or whether actually they have gone back to baseline. This is just my penultimate slide because I can see Beck's coming over, fair enough too. So I just want to talk about this idea that we are celebrating influence today. But when we think about influence and impact, it's really, really difficult to measure. And I just don't want us to think that it's all easy, it's linear. Because actually trying to turn outcomes or evidence, really robust scientific evidence, I hope, into outcomes that can inform policy is not a linear process. It's a really convoluted process that requires you to actually sit down and be humble alongside those policymakers who are bringing other contexts and other evidence to the table, and to work together to try and work out what to do, to also work with communities to find out what they want. So impact and influence is something that we all need to work on as a community too. But it is something that I think we can do, particularly with cohort studies, very well. So I hope I've convinced you that cohort studies do have value. I think we'll hear even more of it during the day. I just want to echo what Beck and others have said, that I think as we move forward, trying to actually bring some of these very underutilised resources together so that we can find out what works across contexts, what works across time, what works across different populations, different policy contexts, and actually understand how we can inform the well-being of our own populations out of that is critically important, and that is something that I'm hoping to drive alongside the RAIN study and other studies in Australia and New Zealand, and increasingly across the Southern Hemisphere, working with the UK. So we're hoping that we can do even more going forward. And I think our methodologies that are evolving as well will help us do that in a much more timely way as well. So I look forward to the rest of the day to hearing what's happened from RAIN. And I just want to finish by acknowledging, as we always must, our wonderful families who are part of the Growing Up in New Zealand study. This is a wonderful woman, Dame Fina Cooper, who led the land marches around 50 years ago in New Zealand. She put it best when she said why we do what we do, and that is because we value our communities, we value our countries, and most importantly, we need to value our children, because what they see, what they hear, and what they feel, that is who they will become, and who they become will be who we are as a population going forward. So I think she's an amazing woman to emulate. Thanks for listening.